You've been told to focus on your bad cholesterol, but what if that's the wrong number entirely? What if I told you I dramatically lowered the single most important factor for atherosclerosis, not with statins and without changing my diet? This is a critical issue because the root cause of plaque buildup is silently progressing in most people over 40, and the standard tests often miss it. But today, you'll discover the one safe medication and the specific activity that helped me achieve this. I'm Professor Vitalis, and in this video, I want to show you, using my own example, how to do it. Let's start by looking at an analysis I did just a couple of days ago. My Apolipoprotein B level is 0.44 grams per liter. It's so low that the lab flagged it as abnormal. Although, to be honest, I'd actually like it to be even lower. But alright, this is good enough for now. Briefly, as I've said many times, Apolipoprotein B, or ApoB, is a far more reliable predictor of whether atherosclerotic plaques will form. The higher your ApoB level, the worse it is. It shows your risks much more accurately than the traditional LDL cholesterol. Why? Because LDL cholesterol represents the passengers inside the transport vehicles, which are the lipoproteins. Apolipoprotein B, on the other hand, represents the number of transport vehicles. We need to know how many vehicles are on our road because the more cars we have, the more likely they are to cause a traffic jam. An analogy. Imagine one road with 100 people sitting in a single bus. On another road, you have 100 people, each sitting in one of 100 separate cars. We understand that where there are 100 cars, there will be a traffic jam. The number of cars is your ApoB level. It's the number of particles that can penetrate the artery wall. Cholesterol is just the passenger. We're interested in the passengers, but it's a surrogate marker. We assume that more passengers theoretically require more vehicles, but that's not very precise. You can use buses or you can use cars. That's why we measure Apolipoprotein B. So why isn't it measured routinely in clinics, simply due to established tradition? Obviously, current guidelines still have everyone looking at LDL cholesterol levels, but I think this situation will slowly begin to resolve. Why is Apolipoprotein B considered so dangerous? Because for the last 30 years, a massive amount of evidence has proven that it is the leading factor in the formation of atherosclerotic plaques, which then lead to heart attacks and strokes. Yes, of course, there are risk factors that amplify the effect of ApoB. These include high blood pressure, smoking, high sugar, diabetes, insulin resistance, thyroid disease, autoimmune diseases, kidney disease, and on and on. But Apolipoprotein B remains the primary link in the chain that leads to all further calamities. So why do I believe the ApoB level should be 0.44 or even lower? Because if we look at a newborn baby, their level will be approximately 10 to 30 milligrams per deciliter, or 0.1 to 0.3 grams per liter. A 5-year-old will have a level of around 0.5 grams per liter. And you know, children's organs and systems develop very rapidly. They don't complain about anything. This also proves that there are no negative consequences from having a very low Apolipoprotein B level. There are even some animals that have no Apolipoprotein B at all. And there's one more piece of proof. Observations of people with naturally low levels of ApoB and LDL. I see such people, though not often. Even at 70, 80, or 90 years old, their arteries remain clean. They don't suffer from heart attacks or strokes. And why? Because they have very low levels of Apolipoprotein B. This also proves there is nothing dangerous about it. These people live to a ripe old age with clear minds, feeling wonderful. And that's why we should also aim for such numbers. But you'll ask, then why do lab reports show different target levels? For example, a person with an average risk might be told to maintain an ApoB level of, say, 0.9 grams per liter. A person with a moderate risk should aim for less than 0.8, and a person with high risk needs to be below 0.65 grams per liter. The thing is, all these calculations are based on a 10-year risk assessment. That is, will you have a cardiovascular event within the next 10 years or not? If the probability is 5%, you'll have one target level. If it's 10%, you need to lower it even more. But a question arises, Isn't atherosclerosis a lifelong phenomenon that accumulates over time? The longer we are exposed to high ApoB levels and the higher their concentration, the worse the prognosis. So why did we decide that 10 years is enough? We need to consider lifetime risk, just like we do with smoking. It doesn't occur to us to tell someone, your 10-year risk factors are this and that, so go ahead and smoke for 10 years, then quit. We understand it's better not to smoke at all, because even one cigarette, even 1 year of smoking, creates serious risks for both atherosclerosis and lung cancer. We must look at the problem of Apolipoprotein B in exactly the same way. Now, let's get back to my results. How did I achieve this without statins? Statins, as you know, are drugs that reduce the intensity of cholesterol synthesis in the liver. I achieved this with Ezetimibe. Ezetimibe blocks the absorption of cholesterol from the gastrointestinal tract. But it's not just the cholesterol we eat. I consume very little of that anyway. Before I started taking anything, my ApoB level was around 0.73, and that was with me making an effort. And now, you see, it has dropped by 40%. How? It's because our body secretes about 2 grams of cholesterol per day, with bile, both as free cholesterol and in the form of bile acids, which are also made from cholesterol. And normally, almost all of this gets reabsorbed back into the body in the small intestine. But when we take Ezetimibe, the process becomes a one-way street. Cholesterol absorption stops, and we lose 2 grams of cholesterol every single day. Consequently, the cholesterol stores in our liver cells decrease. The liver cells start to worry and begin to grab cholesterol from the LDL particles circulating in our blood. And as you know, it's those LDL particles that carry the Apolipoprotein B molecules. By capturing these particles, our liver lowers the concentration of Apolipoprotein B in the blood. And hooray, we've achieved our goal. The only thing that might raise a question is how my ApoB levels dropped so well when all the guidelines say Ezetimibe is a rather weak drug. And many of you who have taken it probably realize that you haven't seen any amazing results from it. The thing is, if you do nothing else and just start taking it without any other measures, it will reduce your LDL cholesterol by about 15, maybe 20% at most. But it lowered my ApoB by over 40%. That's all because I run. The fact is, during running, and I also walk a lot, a large amount of a digestive system hormone called cholecystokinin is produced. Cholecystokinin promotes the emptying of the gallbladder and the release of bile. So now we understand. The more bile is produced, the more cholesterol is dumped into the intestinal lumen. And since Ezetimibe is active, this cholesterol is not reabsorbed. It all goes out. Consequently, the body begins to lose a large amount of cholesterol. By the way, I remember a question from a previous video. What about using a vibration platform? No, guys, that doesn't work. Cholecystokinin isn't produced just because of vibrations when you run or walk. What's also very important is the sustained redistribution of blood flow towards the working muscles and away from the gastrointestinal tract, which happens during physical work. This can be achieved with slow cardio workouts in my favorite zone 2 heart rate. It's not difficult. You can sustain it for an hour, and it's excellent for promoting the release of cholecystokinin. Just out of curiosity, have you ever had your Apolipoprotein B levels checked? Let me know in the comments below. You can actually observe cholecystokinin's effect in a phenomenon known as runner's diarrhea. This is when runners, especially on long distances, sometimes feel the urge to run not to the finish line, but to the toilet, because they get a strong cramp. So this improved peristalsis is another indicator of cholecystokinin's action. In fact, cholecystokinin also regulates our appetite, so its release is generally very beneficial. And as we can see, and this isn't just my example, I have patients who use Ezetimibe very successfully and naturally have ideal Apolipoprotein B levels. I personally am now taking 10 milligrams every day. I was just interested to see how it would work. I have patients who take 10 milligrams 3 times a week. Since there are no side effects, why not take it every day? But let me add immediately, this is not a treatment over the internet. I am not prescribing anything to you, just informing you of a possibility that if you want to put it into a practice, you must consult with your doctor. Well, that's all. The key takeaway is that by combining a safe medication like Ezetimibe with consistent, moderate cardio, you can powerfully influence your ApoB levels far beyond what the drug can do on its own. If you found this detailed breakdown valuable for your own health journey, consider subscribing to the channel for more evidence-based strategies.